Good afternoon. My name is Adam Rubenfire, and I'll be moderating today's Modern Healthcare webinar, Rethinking Standardization, Leveraging Your Team, Clinical Partnerships, and Data to Drive Quality and Patient Value. Reducing variation in care is now more important than ever and can impact tens of millions of dollars in savings while improving outcomes and efficiencies. Yet, despite varied recommendations, truly sustainable strategies are still elusive. Today's webinar will encourage attendees to rethink common avenues of standardization to leverage the skills, experience, and perspectives of all team members. We'd like to thank the sponsor of today's webinar, Schumacher Clinical Partners. Schumacher Clinical Partners is one of the nation's largest and fastest growing healthcare organizations. As a physician-driven company, Schumacher Clinical Partners helps its 7,500 providers focus on discovering innovative solutions and delivering high-quality care to patients. They partner with 400 facilities across the country and offer programs that cover the entire continuum of care, including emergency medicine, hospital medicine, urgent care, telehealth, intensive care, wellness, and post-acute care. A couple housekeeping notes before we get started. We want this webinar to be an interactive experience for you, our audience. You are encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. Our speakers will try to address as many of your questions as they have time for. In addition, if you'd like to minimize the attendee panel for a better view of the presentation slides, click the double arrows at the top of the panel. You can resize the webinar window by grabbing the corner of the screen with your mouse, and you can download several white papers from Schumacher Clinical Partners via the handouts pane of your attendee panel. And now, I'd like to hand it off to your presenters for today, Dr. Randy Pilgrim, Lisa Fry, and Dr. Beverly Gladney. The floor is yours.
Thank you very much, Adam. We appreciate it very much, and thanks to all of you for dialing in today. We are really pleased to be here with you. Myself, Lisa Fry, Dr. Gladney, we're going to talk with you about something we feel very passionate about, actually, and that is standardization of care, and in particular, as Adam was mentioning, rethinking standardization. So we are a clinical service partner that does predominantly emergency medicine and hospital medicine, as well as the other services that Adam was mentioning earlier. And our own history over several decades has actually been very much involved with standardization of medical care in a variety of situations, a variety of settings. The realities that healthcare has delivered for us, however, has caused us, as well as our hospital partners, to have to rethink standardization. So we've come up with a number of solutions, a number of different approaches that we have found to be very successful, and we want to share them with you today as you yourselves think about how to respond to a healthcare environment where, like never before, there are more treatment options, more diagnostic options, and a much more educated patient population than what we've ever seen before under more scrutiny. So rethinking standardization is probably very much in order. And if that wasn't enough, and it should be plenty, actually, there's another big why, and that is, if you don't do this, it's very costly. And frankly, if you do this well, there's opportunity now. This is another great article that we've seen amongst many. This one from the advisory board that says that for every $1 billion in revenue, a typical provider organization has the potential to save or realize $20 to $30 million per billion of revenue from actionable care variation reduction opportunities. So this study, again, like many others, has said this really does matter. And in healthcare right now, when you've got a lot of drivers, like I said, you've got patient care drivers. We want good, high quality care for our patients, good outcomes for the patients. And we want to know if we're patients that we're going to have a good experience that's repeatable in a high reliability organization. And as I said, patients' healthcare literacy and their expectations are higher than ever before. So we've got to be at the top of our game with this and make sure we're doing very well. The economic drivers parallel those. Decreasing revenue and increasing costs are the story in healthcare right now. So you can't afford to leave any rock unturned as you take a look at appropriate ways to make sure your healthcare dollars are spent well and that you're getting good outcomes for those. Oh, and by the way, of course, there's more robust quality and efficiency measure reporting, even public reporting, even those that are tied to incentives or penalties. So there's a lot of drivers there as we transition to value-based models. So we want to present for you today a new how. That new how will build on a lot of the history around standardization of care, but we believe that there's accelerators and new themes and concepts that are appropriate to bring to bear. They will balance the art and science of patient care, they'll leverage the team, and importantly, leverage data through repeatable systems that give rapid cycle feedback and effectively utilize clinical partnerships to fill the gaps that you may have. Once again, there's been decades of trying here, and I will say that we drew on a lot of the wisdom that's out there already, but we've also drawn a lot on our own experience. So what's different? What we're going to talk with you about is we're going to talk about standardization, not just of the clinical care for the patient. We're going to talk about standardizing the processes that surround that delivery for the patient, and very importantly, about standardizing the management that surrounds all of that even. So you'll hear those three themes as we talk together today. And there's the three of us, myself again, the Enterprise Chief Medical Officer for Schumacher Clinical Partners. I've got a 2.5-decade history since my residency training and board certification in both clinical, administrative, executive functioning, and my passion is one of these, and that's the delivery system reform that we're in the middle of right now. With me is Dr. Beverly Gladney, Senior Vice President, Group Medical Officer, and together with her couple of decades of clinical and administrative history, she also has a lot of experience in hospital leadership and interface, and in her role as Senior Vice President and Group Medical Officer, Beverly's role sits right at the interface of the provider group that provides the care and the facility executive leaders and the departmental leaders that are all involved in standardizing the care. She's got some great examples of what we're going to talk about today. And I'm going to toss this in a second to Lisa Fry, our Chief Growth Officer, who after a couple of decades as well of consulting history with C-suite and with senior leaders in hospital and health systems. Essentially, Lisa's role with us, as it has been in the previous, is to unravel complex issues, put together standardized solutions, and essentially cause a good pathway so that standardized solutions not only start, but continue. So Lisa.
Terrific. Thanks so much, Dr. Pilgrim. Well, as Dr. Pilgrim touched on earlier, the benefits available from standardization initiatives really are very significant. And so as most of you know, those of you who've worked in all sorts of healthcare organizations and settings, you've already done a lot of the significant heavy lifting over the past decade or two to really take out excess costs from your organization. So there really isn't a whole lot of low-hanging fruit left. So standardization, as Randy was just speaking about, is really one of the greatest sources of additional potential value that can be created, both in terms of the raw financial value, but really in terms of the overall outcomes value for patients and providers alike. And we really feel that the importance of that opportunity is further magnified each and every day by the dynamics of our current healthcare system. So first, as you all know, we're dealing with ever-increasing patient expectations. As they get, as people get more consumer-focused and see that experience in other aspects of their lives, they expect that same consumer-focused experience from healthcare aspects of their lives, and especially as they share and shoulder more and more of the burden of the cost of that care every day. So you've got that dynamic to deal with. And then really we also face the constant additional complexity and proliferation of treatment options. So in every sense of that word, technological options, therapeutic options, and process options, the care gets more and more complex. So standardization is all the more important as a result of that. However, despite all those things, and despite the fact that those things amplify the opportunity, and that there is that potential out there to capture, it still proves elusive to us, especially to maintaining the gains that we make sometimes from standardization. And it's often because of some of these very common pitfalls that you see here. So one of the biggest things we see is you under-resource the initiative, especially in terms of providing the data and feedback real time to the teams that are involved in these standardization processes. Second, you obviously see competing priorities. Those of us who work in healthcare every day can truly appreciate that some days you really do have to put the urgent before the important. But those competing priorities can definitely sidetrack important initiatives like this. And then lastly, we're going to spend a fair amount of time on this today in much more detail. You've really got to think about those stakeholder viewpoints. And there are lots of different viewpoints that you can take into account there. So in the next 50 minutes or so, in the time that we have remaining, we hope that we'll provide you with a new framework to really think about how you're going to engage those 5 key stakeholders that we're going to talk about in just a few minutes. And Dr. Gladney is going to give you some examples of what we've seen in terms of successful standardization efforts that we've experienced. We'll talk a little bit about what those have in common, and then we'll give you a brief overview of the role, in our perspective, the role of clinical partnerships and the role that they can play in helping you be successful throughout that process. So, in order to keep things a little bit more interesting, also we're going to provide you with some polling questions and take your pulse on things. So, Adam, I think at this point we are ready for our first polling question.
Well, fantastic. Thanks for the presentation so far. I will load your first polling question. So the first polling question is, if you've seen standardization fail in the past, what was the main reason? Was it too hard to implement or sustain? Was there a lack of a common goal, poor overall plan, some poor data or feedback, or was it something else? Please answer the question by clicking on one of the answers on your screen. We'll give participants a few moments to choose their answer. And just a few more seconds, we'll be closing the poll. So if you haven't voted yet, please vote now. Okay, here we go. There are your results.
All right, great. Well, it looks like the majority of you with us on the call today have had some experience with several of the common pitfalls here. But the most common challenge it looks like that you all have faced as you've gone through this type of process is really it's very difficult to implement or sustain this type of change. And that's often because it's really a multidisciplinary or multi-department effort, which naturally increases the complexity.
And that's what we found also. You hit the nail on the head. Now for a quick peek of what's to come. In one of our partner hospitals, the readmission rate for congestive heart failure patients missed the target as it was over the national benchmark, so needed to be addressed. What did we find? A multitude of hospital-based resources with lots of variation in their utilization, so unsatisfactory results in the end. What didn't we find? A plan for standard operating procedures. So what did we do? We implemented standardization of a clinical pathway to meet our target. We came away with impressive results and an elevated value, not only for the hospital, but providers and patients. I will have much more detail to share later, but before that, it's important to anchor ourselves in some foundations and fundamentals.
So thanks, Beverly. That's a preview of some of the more specifics that we'll get to later. And as Beverly said, I've got about 3 or 4 slides here that we have found very important as we've implemented standardization efforts. And for those of you that are waiting for the ready, set, and want to get us to the go, I will say that that's one of the reasons that we're pausing on this, because we've seen a lot of standardization efforts get going before they anchored themselves in foundations and fundamentals. So let's make sure we do that first. Briefly, we found these to be very important. So there are 3 objectives of a robust quality program that we have found, again, very helpful. Number 1 is to meet or exceed your targets. Number 2 is to reduce the variability around those targets. And number 3 is to trend positively over time. So let's take those apart briefly. Meet or exceeding targets means that you have to know what it is that you're doing and how to measure it. And then, of course, what target performance is. So there is a lot in there, and sometimes it's fairly simple. If you're door to provider time in your emergency department, you have a number, that's usually in minutes. You have a target, let's say that's 12 minutes or 15 minutes, and then you can measure it from there. But that's an easy one. There may be ones that are more difficult. So number 1 forces you to identify that clearly and to identify what target performance is. There's a lot of art to that. Number 2, reduce variability around that. That means for those of us that have managed a lot of things over time, you know that almost always your average might not at all be what your certain patient's experience was. So on average, if a patient complains about what they've had or experienced with you, repeating back what your average is may not exactly match their experience. So we want that variability to be very small. And then, of course, over time, we want to trend positively. Now, the interesting thing about that is those 3 foundations. When you take a look at number 2, the reducing variability, standardization efforts actually unify and empower the other 3 all 3 objectives. It creates sustainability, it enhances value, and again, most of us have done this over time, know that in order to get better, you take your low-lying outliers and move them up. Of course, you want to sustain and empower the ones that are doing well, but that's heavier lifting, usually than not. So meet or exceed targets, reduce variability, and trend positively. And if you're listening carefully to this with a data mind, you'll say, you know what, I bet I know how to structure my dashboards and my data systems now in order to show whether or not those things are happening. So that's fundamental number one. Fundamental number two in this new framework is that we have to deal effectively with common potential misconceptions about standardization. And I'm calling these misconceptions. They are so common that your system of implementing this actually has to regard them, expect them, and have good answers and good data and information around them, because they're going to come up. As a physician, I can say that so frequently my colleagues and even myself at one point in my training, I thought that standardization was around disregarding my medical training and my clinical judgment. Why in the world would I go to 9 years of medical school and residency fellowship and everything else only to find out that a cookbook superseded all that, right? So there is a misconception that that is actually what is happening. And when we talk about our stakeholders, we'll talk about how we can actually fold in the training and clinical judgment. We'll talk about that in a minute. Other things you'll see is this is impersonal care. So on the patient side, they get the cookbook approach too, maybe, right? In other words, this is what we're doing, this is how it rolls, and I don't care who you are. That can be how it can feel. The other is that it's all about the money. Like the only reason we're doing this, and I even put that as the first slide, and I sort of baited you that way to be quite honest with you, is that it's partly about the money, but it's a lot about the clinical care also. And other misconceptions, it's too hard to define, too expensive to implement, not sustainable, which honestly, the poll question we just took sounded a lot like that. So that bled to our core concepts. And hang on, we're getting to go here in a minute. Number one, we have to leverage the perspectives of all 5 stakeholders so that their misconceptions or fears are not disregarded, but they're actually folded in. Number two, a core concept is we balance the art and the science of patient care. Not the science alone, not all art alone, but we balance the two. And the third is to create value. On those perspectives, on those core concepts, here's the things that I would say. Number one, the 5 key stakeholders that we're going to talk about in some length. Once again, these are very significant to us because as we have failed in our own attempts from time to time or watched others fail, we have found that if you don't involve all 5 of these key stakeholder groups and understand where they're coming from to start with, you may not be successful. So this is a quick preview of something Lisa's going to talk with us about in a minute. Healthcare executives think of standardization often as predictability. Providers think of it often as evidence-based. Can I use good clinical evidence here? Payers think of it as cost-effective. Some think of it as cheap. I know that, but it's cost-effective at least. Nurses will often think of it as consistency in my day, in my care, and in my process. And patients think of standardization as personal and effective. So what we're going to do is embrace and integrate all those perspectives, and Lisa will detail that. That increases buy-in. And once again, we're saying this early on because if you don't do that, you may not get your efforts off the ground. And even if you do, they may not stay in the air. Second or third concept is balancing the art and science. The art of medicine, in our terms here, are the patient perspectives and individual characteristics that make every single clinical encounter unique. The science is the recognized and standard and, where applicable, evidence-based approaches for patients that present similarly and have similar stuff. The real key is to be able to balance this because if you get too much art, it means that almost anything I want to do as a clinician is okay, and usually that means significant variation. And as I said earlier, there's a lot of therapies and a lot of treatments and a lot of workups that are available now, and that additional expense, as another article I just read literally this morning, is that when you actually do this on a very patient-centric way, you find that the expense is moderated and the quality is actually enhanced. So that said, too much art is not a good thing. Secondly, too much science. That just means, again, back to my colloquialism here, the cookie cutter, that reduces personalization. It disregards uniqueness, and patient outcomes and experience may suffer as well. So once again, your efforts must balance that. And the trick there is to not become overly glued to what the number is. You have to be overly glued to the outcome and its value, which is classically defined as quality divided by cost over time. So this is the third core concept. We're going for value here, which means if all you do is cut cost, well, actually, mathematically, you do drive value because that's the denominator, cost. What we want to do, though, is make sure that quality is enhanced or at least maintained if you're already in good shape there, and that cost is moderated. Again, this is high value care, and over time, that's what happens. So you do get better outcomes, better cost, and a better patient experience. There's tons of data on that as well. And frankly, there's a better provider experience despite some initial questions and concerns that our colleagues will often have. So putting all that together, when you hear what Lisa and Dr. Gladney are going to talk with us about, keep those fundamentals in mind. And again, it is worth investigating those carefully before you launch a standardization effort, because if you do that, you will have data that speaks to that. You will have prompt and meaningful feedback for stakeholders. You will have reliable clinical and management reporting systems because you actually have to have them. You have to have that data and not just one-off systems that do it. And often that requires a like-minded, effective partner in the complexity of healthcare today. So let me turn it over to Lisa for
Great.
how to.
So now we're going to talk a little bit more about how we apply those foundations and fundamentals. And as with most things in healthcare, it really centers on the people. As all of you know who have worked in this industry, healthcare is really a team sport. It's delivered by people, and so we really need to keep some basic rules of engagement in mind as we start to think about how we apply our framework. So first, we really need to think about how we respect and value the perspectives of each team member. I'm sure we can all agree that multiple heads are better than one, especially when it comes to facing complex challenges. So in doing that, we really need to ensure that the team considers all of the input from a wide variety of perspectives to get the best solution. So for example here, it's often important to think about developing a patient advisory council in your facility to use as a sounding board for new initiatives, which could have a significant impact on the patient experience. Could be standardization, it could be other things as well, but we often find those to be very, very helpful in making sure that we've incorporated and respected the perspectives of patients. Next, we need to consider how each team member views standardization and really possibly reposition the initiatives in their terms and in terms of what's important to them so that we really develop and ultimately deliver a better, well-rounded solution to whatever challenge we're trying to address. Next, we really need to ready them or prepare them, essentially equip them with the data, the resources, and the tools they need to be successful, and especially work toward embedding those resources within workflows where possible and where applicable. So we typically recommend we use a Plan, Do, Study, Act methodology to incorporate real-time data and progress updates to our provider teams as we incorporate new initiatives. And then we tweak and we study it a little bit more, and we look at the data, and we see how all of the impacts unfold. And then Dr. Gladney is actually going to talk about that a little bit more in a few minutes. And then lastly, we really need to reward and recognize the accomplishments and the successes of the team so that we can reinforce that change management behavior and move forward. So now we're going to dive into the details about the stakeholder model we call the bullseye that Dr. Pilgrim talked about a few minutes ago and introduced the concept. So the thing to really keep in mind here as we go through this is that the overall goal here is to balance the views of all the team members and not allow the teams to get overpowered by one or more of the groups. And we typically, many of us see certain groups within a particular team or facility be more influential than others, but that balance is really important. So we really expect and hope that they each bring a unique perspective, and it's really our job as a change management team to harness those perspectives to optimize the outcomes. So we'll start first with healthcare executives, and as we talked about a little bit first, they typically come from the perspective of seeing the benefits of standardization as focused on predictability, which then yields efficiency potentially in the system and improved patient safety as well. So there are probably, I would assume, many of you on the call today who fall into this group. And you'll typically be focused on setting measurable goals for this kind of initiative and really helping to define what success looks like for the teams. But I think the thing that you need to keep in mind, if that is the hat that you wear within your organization, is to be mindful to include all viewpoints in what that definition of success really looks like. so that you can optimize the engagement of all of these folks that are involved, and really that adds to the long-term support for your initiative and the sustainability of it ultimately. So the more engaged the full teams are, the better your chances of sustainability overall. So the next group to consider is the providers. As Dr. Pilgrim talked about, obviously many times the providers come to the table with concerns about standardization being perceived as applying too much science and not enough art, and possibly representing for them a loss of autonomy or reducing their role or minimizing their role in clinical decision making. So we've got to really be careful to first and foremost, seek their input and get them involved in the entire standardization process. You've got to bolster that involvement with robust data and proof. So most providers are scientists and data-oriented folks, really focused on facts. And so you've got to make sure that the processes that you're considering putting in place are evidence-based and that the outcomes can be proven to really outweigh the key trade-offs. So again, this is one of those critical places where you can really apply your data and technology and analytics resources across your organization and across this team. So next, we think about the role of nurses. These types of initiatives often have a very direct impact on their job satisfaction. So to the extent that we can make nursing workflows easier and more consistent, that's typically viewed very favorably by the team and result in benefits like improvements in patient experience, because you have happy people delivering care, they typically deliver that in a more effective way from a patient experience perspective. So nurses are very often the team that have to execute these new initiatives and workflows on the front lines with patients every day. So as you're going through this process, making sure that these approaches work for them is absolutely critical to the success. And so you've got to be sure to include them early and often in your standardization work groups and initiatives. Next, we think about our patients. So for patients, the most important thing typically is that they feel that their care is both personal and effective. So they can often resist standardization if they come to the interaction or the encounter with that provider with a specific preferred alternative or a treatment expectation already in mind. I mean, goodness knows there's enough resources out there on the internet now for patients to self-diagnose fairly frequently. And how many of us have been through that experience of trying to implement a standardized pharmacy formulary, only to be faced with objections from patients because they've seen a commercial for a great drug on TV and that's just what they want and nothing else. So we really have to be mindful about the impact that these types of initiatives can have on patient satisfaction levels and the perceptions about their care. So what we typically do to really focus on that is carefully consider how are we going to communicate to patients about their care and give them the reassurance they need that they're getting care based on extensive research and medical evidence, and while still leveraging the expertise of their individual provider who they have that personal level of trust with to really ensure that their treatment recommendations are personalized to their unique situation. So it's important to meet them where they are in terms of communication and education, and then that ultimately leads to increased compliance with treatment recommendations and hence, in the end, better outcomes from a patient perspective. Lastly, we think about the payers, and this is probably one that is more commonly left out of the equation. They often are viewed and often believe that standardization is a very positive thing and that can promote cost-effective healthcare across the system. And what we would encourage you all to think about is you do need to consider their perspectives so that you can better position our healthcare organizations, your healthcare organization, to partner more effectively. There are things that come up. They're on a case-by-case basis. There are case management exceptions, for example, that need to be made about specific patient cases. And you'll find yourself, in a situation where you really need to be working with a payer on that. And having a more evidence-based approach is typically very helpful in those types of situations. And then you've got to think about also your payer relationships from a macro level. So to the extent that your facility is effectively differentiating itself from your competitors in terms of better evidence-based practices and putting those into your processes and into your daily workflows, you really better position your teams and your managed care folks to negotiate more favorably with the payers as well. So as we consider some of the key perspectives of all of these stakeholders, it's very common, as I just said a little while ago, to see one particular stakeholder group that may overpower the others in either a specific organization or maybe in a specific type of situation. So Adam, it's time to take another poll.
Thank you. We'll launch that poll right now. So the second and final poll is, which of the 5 key stakeholders is most dominant or influential in your institution? Is it the C-suite? Is it providers, nurses, patients, or payers? We'll give you just a few moments to vote. Please choose your answer by clicking on the bubble next to the answer on your screen. We'll give you just a few moments to vote. And just a few more seconds, we're going to close the poll. So if you haven't voted yet, please vote now. Okay, I'm going to close the poll and show the results. There are your results.
All right, terrific. Okay, well, we certainly do have a variety of opinions, but actually a pretty dominant choice here with the second one, which is providers. And certainly with physicians and other providers, as we said before, the key here is to really engage and involve them in the clinical process decisions and support them with real-time data and evidence wherever possible.
As Lisa said, this is true in so many places. Now you'll see how your dominant player can take the initiative to lead, guide, or just be a team member in the multidisciplinary care that must occur with the standardization process. A little bit ago, I told you about a community hospital with increasing readmission rates for congestive heart failure patients. Then Dr. Pilgrim spoke about foundations and fundamentals of standardization. Lisa discussed the rules of engagement and how to hit the bullseye for high-value patient care. Well, here's the real-life example of how this plays out. Remember the challenge: high readmission rate with a penalty to the hospital, which led to decreased reimbursement. Now, if you're looking at the chart and thinking, well, this is really not significantly over the benchmark, true. But the hospital was not happy with this, and if you are the patient, you don't want to go back for another hospital stay either. Now, interestingly, the hospital did have lots of pieces of the puzzle with social services, case management, pharmacy, dietary, to mention a few. However, the patients did not receive their help many times because there was no process of care. The puzzle was still just pieces. There were many teams unaware of what others were doing. So you could say there was no collaboration between emergency medicine and hospital medicine, or between pharmacy and nursing. Physicians and nurses were not even aware of the resources available to them, nor how to incorporate them effectively. The ED was not seen as part of the solution, just a problem area, as they had frequent bounce backs, didn't know why, or how to prevent this from happening. So, what was the solution? Well, let me tell you the elements of the solution as we rethought standardization. Patient care, that mainly happened in the ED. The middle element, which was processes, patients might have received good care but got lost in a variety of processes. And then last, which is really important, the management of this care with emergency medicine, hospital medicine, administration, collaboration. Because without it, success will never happen. So the big key, we standardized the management of all the above, meaning there had to be coordination of many moving pieces and people consistently to reduce variations and inefficiencies. In the emergency department, order sets were added to the electronic medical record. Admission order sets for CHF patients were implemented in the ED also to bridge patients to the floor. If a patient was discharged from the ED to home, providers and nurses utilized the patient education checklist so the patient knew what to do when he or she got home. And follow-up appointments with, say, cardiology, primary care, renal, home health were made right from the emergency department to complete continuity of care. With hospital medicine, the processes became even more important as patients stayed 3 days or longer instead of just 3 hours in the emergency department. We had to reduce care variation and ensure critical steps were never missed. Home health, social services, case management, all were consulted immediately upon admission as opposed to waiting until the day of discharge, as was previously done. Underutilized resources such as hospital, palliative care, hospice, and palliative care became part of the consultation process, and a core measured checklist was also included on the order set to ensure compliance. Discharge instructions were rewritten, organized, improved, and standardized so that a more complete set of instructions and education was given to each patient and family. The last step in standardization of this process was to automate the hospital stay summary to the primary care provider and cardiologist to continue coordination of the patient's care. But most important was collaboration of an aligned goal, first and foremost, then standardization of collaboration. Once again, if you don't do this, you will fail to launch, and no one wants that. The JOC, or Joint Operating Committee as we call it, was the glue, absolutely essential, the place for communication, collaboration, and course correction. It included a balance of emergency and hospital medicine, physicians and nurses, and administrators. The reason it was the glue and the way it got things done was having a standing group. If you didn't have them all, you didn't have a meeting. There were standing agendas for consistency. There were recurring review of all CHF fallout and joint revisions of the process where needed. During the JOC monthly meetings, hospital resources were brought to the table, reviewed, retooled, rescaled, and became part of the evolving process. Interdisciplinary rounds were begun with all ancillary partners to provide coordinated care and early intervention for the patient. Let me give another example of another piece of glue, that is, representation of some data regularly shared at the JOC. So once targets were identified and known by every provider, they then had to know where their performance fell and if they were trending positively over time. So whenever you have this data, as seen here on our provider portal, you must provide this transparency to everyone involved so improvements can be made. And what happened? Well, results were impressive as the readmission rate after implementation was certainly on target. No more hospital penalty, no more declining reimbursement. But I think more importantly, it increased patient engagement as patients now became a part of their decision-making team, involved in their own healthcare education, and hopefully had a more positive outcome and experience. Providers became more engaged with patients and all of their hospital partners as they utilized all resources needed to manage their patient. There was certainly a decrease in practice variation when continuous feedback was given to outliers using data analytics. And then using this feedback, there were then opportunities for revision of processes. And all of this occurred, a big point here, with resources already within the hospital. So no new expenditures were needed. The takeaway from this real-life example is this was an exercise in behavior management for sure, but it changed individual responsibilities into a healthcare responsibility. Standardization of processes has also worked for our other hospital partners to meet targets such as their front-end process or any throughput processes and pathways such as sepsis. Standardization is an indispensable process which can be implemented to fit any one of your hospital's performance measures or goals, to spread knowledge, boost accountability, bring order and cohesiveness. It just makes life easier for everyone involved.
So a great example of how all this worked in actually a fairly complex example, and you did that on purpose. That was very well done, and it worked very well for the facilities you just mentioned. There are much simpler examples of standardization, which we can go through, like antibiotics for sinusitis or some of the other more common presentations of patients, but that's a complex one on purpose to show you the inner workings. So let me fold all this together. Beverly talked about standardizing care, standardizing the process of care, and standardizing management. I mentioned earlier the core concepts, so let me tell you just a little bit to call to mind here. Again, to fold this all together, the 5 stakeholders were involved. You mentioned the patient, and I love that example. Not only the patient education, the patient advanced directives, but also asking that we actually knew exactly who these patients were. We went to them and said, how would you like this to work better? Where do you think our gaps were? So involving them. So that was one stakeholder. The second one is the healthcare executives. Just their presence and buy-in alone at the joint operating committee level was huge in that. And so they were able to say, you know what, when CHF patients come to this institution, there's a more predictable pathway that they're going to have that connects with it. So they were involved, and without their involvement, that would not have worked nearly as well. The providers were involved because they not only drew upon industry knowledge about order sets and about admission and consultation guidance, but they actually were involved in actually either making that fresh or certainly implementing it once done. The nurses were involved. Again, multiple departments, multiple settings, and as Dr. Gladney said, a lot of the resources were already here, if not all of them already, but the pieces weren't connecting, and a lot of that is connecting the nursing components. So they were intimately involved. And finally, the payer, the 5th one. Now, interestingly, in this example, the payer was actually prescriptive already. We already had CMS guidelines about readmission penalties for CHF. We already had core measures then. We already had a number of things that were either publicly reported, internally reported, or had penalties or incentives. But we had to know what those were. And even though CMS certainly didn't fly from Baltimore down to this facility every day for a JOC, we were very well aware of what their guidance was. So we leveraged the perspectives of 5 stakeholders, and that was a piece of its success. We also balanced the art and science of the patient's care. Since the providers, the physicians and nurse practitioners and PAs were involved early, they knew that their perspective was valuable, and they felt both the liberty as well as the aspiration of getting this done well. That alone got that done. And then we created value in the course of this. There's other data we can share with you offline about what this actually did in terms of increasing quality and decreasing costs together over time. So again, bringing that all together, it was important actually to have a partner to do this with, because the data, the systems, and the reproducible elements that Beverly showed in her data slide, that's just one example of what needed to happen. And it wasn't only a monthly report, it were daily and real-time reports as well. So people knew where they were. They knew whether there was a decrease in variability, and they knew whether there was a positive trending that was happening. Again, the core elements of a robust quality system. Now, I said early on, and again, I somewhat baited you with this. If you're an organization that is already on this, you're already reaping the benefit that, again, these quantifications have been made. Per billion of revenue, 20 to 30 million may be available. This is simply one example, but there are many, many others that as Dr. Gladney was saying, we have to standardize care, the processes, and standardize the management. There are a lot of additional materials, though, that even in a short webinar, so that we can get to your questions soon, we want to make sure that you know that there's a lot more information available to you that may be much more specific to the issues that drove you to join us today. Lisa?
Right. So we hope you now are so interested in enhancing your standardization efforts that you do seek out additional resources. And so we have a few of those listed here. First of all, within 48 hours or so of today's webinar, you'll receive an email from Modern Healthcare that will give you access to download a PDF of our slides from today's presentation. Also, throughout this webinar, during your, as you've probably noticed in your participant viewer, there were a couple of other items that you could download. You could download our white paper on this same topic and a couple of other pieces. You can certainly also find those at any time by visiting schumacherclinical.com. And if you really have a specific question, you can certainly feel free to reach out to any of the 3 of us at the email address provided here on the slide, and we'll be happy to have an individual follow-up conversation with you about any of your questions. So on behalf of our team here at Schumacher Clinical Partners, we really want to thank you all for your time and attention today, and we now look forward to answering some questions from the attendees. So Adam, I'll turn it over to you for Q&A.
Well, fantastic. Thank you for that phenomenal presentation. We have some great questions coming in from the audience, and they're coming in real quickly now that we just moved into this section. So fantastic. Audience, if you have questions, continue to send them in. We'll answer as many as we can until the top of the hour, but we are keeping track of your questions and have the ability to follow up with you if we don't get to you. So let's see what questions we have. First question is for Dr. Gladney. Dr. Gladney, this questioner says, I'm afraid I'll get a lot of pushback from our physicians who think that standardization is a way to control them and legislate how medicine is practiced. How do we address that?
Well, I would say if you don't involve them early in the process, absolutely you will get pushback. But engage them from the start as decision makers, especially for clinical decisions, and they'll own it. And I think they would become super users for you. Their input is very crucial. As much of the to-do list falls to them. So I would just say encourage them to customize your processes to fit your particular hospital needs.
Fantastic. And Dr. Pilgrim, we have a question related to CHF readmissions. They said that the questioner is asking, as it relates to post-acute partners like home health and skilled nursing facilities, could you speak to how adding those kinds of partners in into the mix, into what you're thinking about for standardization, how that can increase your impact and improve outcomes?
Yeah, absolutely. We have other examples, not necessarily the one we gave today initially, although it was involved, where the post-acute care was every bit as important as the actual acute care itself, whether it was the emergency department or the hospitalization or both. The early and the sort of integral involvement of post-acute partners is very critical. And frankly, we've been very encouraged about how eager the post-acute service lines, be it LTACs, home health, or other service lines have been to join with us in this. So it would be very easy to add them to the group of the stakeholders that we talked about. And honestly, as is often now felt, the post-acute dollars that are spent in service of the more complex conditions are often the greater dollars over periods of time, like 90 days, as you'll find in the bundled, the BPCI program that's now in advanced APM. So have we had experience there? Yes. Has it been effective? Absolutely. But the same thing as Dr. Gladney said, only if you involve them as an equal partner and a very helpful person, and they know what the targets are.
Fantastic. And Lisa, we have a question for you. The question is, aren't payers the only ones who really benefit from standardization? Why should a provider undergo a standardization initiative?
Mm-hmm. So I would really think back in terms of thinking about who benefits from this to the value equation that Dr. Pilgrim talked about earlier. So if you really think about value and increased value equals, quality divided by cost over time, then I would go towards thinking about really who benefits from increased quality and lower cost. And certainly the payers do benefit from that, but patients really benefit directly from increased quality and outcomes and patient experience, and certainly benefit, as I mentioned earlier, in the fact that they are shouldering a greater burden all the time of the out-of-pocket costs of their care. So I think they both benefit from increased quality and lower costs. And the experience, the hospital or the healthcare provider, I think also experiences both financial benefits from decreasing costs, but also financial benefits from improving quality outcomes to the extent that that's tied to reimbursement. But what I look at that is, the financial benefit to me for the hospital is really a means to an end. What that ultimately does is increases the hospital's ability to provide and continue to provide and sustain access to care and access to key programs for their community. So I do feel like there are many other ways and other, all of the stakeholder groups who really benefit from this besides just the payers.
Sure, fantastic. And for Dr. Gladney, I know you've spoken quite a bit about joint operating committees. Could you maybe talk about how you set one of those up? And the question really is, do you set one up for every initiative, for each initiative, or is there one joint operating committee at the hospital medical staff level, for a range of projects, I should say?
Yeah, we actually set up the JOC to talk about a lot of the different problems and actually an offshoot of the JOC was some smaller committees that just dealt with the CHF pathways and other pathways. So yes, the JOC was a standing group that met, and anything could come to the table for this.
Fantastic. Our next question is about Six Sigma. The question is, our company has used GE Six Sigma and more recently Lean to try to approach the performance improvement activities. What do you find works best in healthcare settings? Dr. Pilgrim, for the sake of order, maybe we want to start with you, and if anybody else wants to chime in.
Yeah, I'll start. I've found that both work is the short answer, and they're often operator dependent. The method themselves, I know that there's data out there, or at least opinions out there, that one is better for healthcare than another. Our experience has been that both work very well, and they're very dependent on the people that are actually using it and how inclusive and effective they are in managing. I don't know, Lisa, if you've had experience similarly.
I have not, but as you said, we do have folks within our teams that are, very fluent in both of those approaches. So I think you've got to really think about the individual problem you're trying to solve and what might fit best for both. But
yeah, and the real question is often, what problem does that method address, and do you have that issue? So just like my toolbox, if I pull out a crescent wrench, but I'm really trying to put a screw inside of a piece of wood, that didn't help very much. It was the wrong tool. So it's a good question, and probably more incisive review would be in order. But once again, we've seen both work well.
Fantastic. Really interesting question here. We can start with Lisa. Lisa, what do you see as the 3 largest barriers to the overall buy-in process to change and acceptance of the standardization process?
I definitely think it's some of the things that we've already talked about today. So, thinking about from the perspective of barriers, first and foremost, just addressing all of the concerns that each of those stakeholders are going to come to the party with. So you've got to really first and foremost think about, where is each party going to come from? So if the providers are concerned about loss of autonomy, you've got to really sit down and have some what we would call crucial conversations up front about the initiative, and make sure that people aren't just complying with this initiative but are really committed to it. So I think that's important and an important barrier to overcome. You really do have to think about the prioritization of this initiative. I know I talked about that early on in the presentation, but competing priorities can be distracting and can definitely be a barrier that has to be addressed. So one of the hardest things to do in leadership and in management is to make the decisions about what you won't do versus what you will, because we all know in hospitals and healthcare in total, we all have 150 more things on our to-do list each day than we have time to do. So that's, I think, the second thing is, I would say, is get that prioritization barrier addressed, and then really thinking about one other barrier that I think is just sort of logistical in nature is that type of cross-functional group that we've talked about is really hard to coordinate, just in terms of getting people together. You've got executives and C-suites and providers and doctors and nurses who are all working, crazy patient care schedules, and really just getting those interactions scheduled and coordinated in an efficient and regular fashion is not a small task either. So I think that's an important barrier to consider.
Fantastic. And Dr. Pilgrim, you talked about data and feedback systems, being critical to sustainability. Do you have any examples of that?
Yeah, we have a ton of examples of that. If I understood the question correctly, I think it gets at the heart of if you have targets and you want to meet or exceed them, you want to reduce variability, and you want to trend positively, the question for you is, do you have data that will regularly and promptly come to the people that need to know whether that's happening or not? And so we have an example, actually, where we had a standardization effort. It was over a couple of key clinical conditions in the emergency department, and we did not have the data flowing at all. So the only answer to how's it going was to ask every individual, and they'd say, I think okay. Well, once we then actually applied the data system that we have, it is ours, it's proprietary, And we were able to give individual provider feedback on those particular measures as quickly as anyone knew it. The provider knows that, both on their iPhone, their computer, and so forth. And it's once it's built, it's easy to apply. And once that happened, people, even brand new providers to the practice, got up to speed quickly. They stayed at or exceeding the targets, and the entire practice lifted in terms of its system. And really, what changed was the data and the transparency. So we almost won't like to implement a standardization system unless we know that we can regularly provide that kind of critical element.
Well, fantastic. Folks, that brings us to the end of today's presentation, but I will tell you, if you asked a question and we didn't answer it, Schumacher Clinical Partners will be following up in the coming weeks, so you can expect that. Well, thank you very much. Special thanks to our audience for the great questions. Thank you to our speakers, Dr. Randy Pilgrim, Lisa Fry, and Dr. Beverly Gladney for your insights on this topic. To our audience, we value your time and feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best content and resources for you. We'd like to thank the sponsor of today's webinar, Schumacher Clinical Partners. For more information about Schumacher Clinical Partners, visit www.schumacherclinical.com. This webinar will be available on demand, and a link to a recording will be emailed to you within the next 48 hours. This concludes today's presentation. Have a great day.